Thank you, Dennis, for that very kind introduction. And I'd firstly like to acknowledge the traditional owners of the land on which we meet and pay my respects to elders past and present. Thank you very much for asking me to speak to you here today. It really is a pleasure to be here. And I'd like to start by acknowledging the President of the Rural Doctors Association, Professor Dennis Passion, President of the Australian College of Rural and Remote Medicine, of course, Associate Professor Lucy Walters, the CEO of the Rural Doctors Association, Jenny Johnson, Ewan McPhee, and there are other distinguished keynote speakers that have been here. I'm not sure if they're in the room at the moment. Dr. Richard Roberts, Dr. Roger Sexton, Associate Professor Stephen Bradshaw, delegates, ladies and gentlemen. Since we last met, it's been an interesting 12 months in Canberra, to say the least. We've had a change in Prime Minister, a change in the ministry, and I am now the Minister for Rural Health. I believe the change in the name really reflects how important rural, regional and remote health is to the government, and I'm very honoured as a National Party Senator to be the first Minister for Rural Health, and it's something that the National Party has been very keen to see. My portfolio responsibilities remain the same, and as you know, rural health issues are a priority for me. Being a rural politician is very much like being a rural doctor. We both have a constituency that can be challenging in their demands, but fascinating in their stories and appreciative of our efforts, although I think perhaps more appreciative of yours than mine. We both have to address a variety of complex issues, often needing to jump from one to the other in a short space of time, and sometimes we are left wondering if we've done every problem justice. We both have to front up each day. Our families can suffer from our absence, and we sometimes have to take on jobs that are frustrating. We both know that no matter how hard we try, we can't please everyone. Ladies and gentlemen, today I want to touch on some of the key areas in my portfolio and to talk about a few areas that I know are particularly important to you, including the implementation of the new geographical classification and rural incentives, rural practice-based training for junior doctors, the new arrangements for GP registrar training, and a changing perspective on medical workforce, particularly in rural areas. There are many important issues, including Indigenous health and drugs in our regional communities. Just yesterday, I launched the implementation plan for the National Aboriginal and Torres Strait Islander Health Plan 2013 to 2023. It is a plan that will deliver action and achievable goals. The plan includes 20 new goals across 5 areas. That is improving the health of pregnant women, reducing smoking, tackling diabetes, lifting immunisation rates, and doing more health checks. The goals are ambitious, as I say, but they are achievable. The primary healthcare sector, in particular the Aboriginal community-controlled health sector, now has the challenge of providing the services and care that will allow us to realise those goals. Another issue I've been working hard on all year is the government's response to the issue of ICE, and leading the work with my colleague Michael Keenan, the Minister for Justice, on our response to the task force report. Earlier in the year, as you would know, we created a task force to advise the government on a national ICE action strategy. The task force, led by Ken Lay with Dr. Sally McCarthy and Professor Richard Murray, who is obviously very well known to you all, did very comprehensive work and has now provided a detailed report to government, and we're now considering our response to that. And I do have to say, I was particularly delighted when Richard agreed to be on that task force. They did a tremendous job, and I'm very appreciative of the time and commitment they put into delivering what is an extremely comprehensive report. The use of ICE in the regions has increased dramatically over recent years, and I've been right across the country in a dozen communities holding consultations specifically on ICE and visiting other communities, discussing what is a really devastating issue in those communities. And we know that our regional communities are being targeted by organised crime and bikie gangs. One of the things that has become very clear is that law enforcement alone is not going to tackle this issue. We're going to have to look at things like education, treatment and rehab services, community leadership, and of course, primary prevention. The role of our GPs in our rural, regional and remote communities is, I believe, going to be pivotal in tackling this drug. The government will respond to the task force recommendations and release the report very soon. Ladies and gentlemen, I see my role as improving the healthcare of people in rural and remote Australia and providing them with access to healthcare that is accessible, affordable and appropriate to their needs. To the extent that this requires doctors and other health professionals with the education, training, skills, professional support and appropriate economic framework and income levels to enable this to be achieved, I am totally on your side in all of these areas. When the Coalition came to government and I was appointed Assistant Minister for Health with the responsibility for the Rural Incentives Program, I was committed to implementing a workable geographic classification system which was evidence-based and met the needs particularly of rural and remote Australians and provided real incentives for doctors to work in these areas. The government, in response to a Senate inquiry and after a period of consultation with communities and professional organisations, adopted a modified Monash model which was based on the research of Professor John Humphreys from Monash University. The research, and I am going to paraphrase here, identified a number of key factors that adversely affected recruitment and retention in rural and remote areas. These factors included workloads, on-call commitments, hospital activity, spousal employment, and schooling. I asked an expert panel to consult extensively with stakeholders and to provide independent advice on how the Rural Incentives Program might be restructured to better meet the goal of providing improved access to appropriate medical care in rural and remote communities. During the process, the issues of isolation and complexity emerged as significant considerations in the delivery of health services to regional areas. I am committed to addressing both of these issues in our consideration of the delivery of incentives going forward. Most Australians would not consider a town 30 kilometres or so by road from a capital city as in fact isolated. However, I do accept that in some of these towns, doctors are providing a higher complexity of service, such as after-hours care or hospitals-based services, than what, say, a metropolitan GP might provide. This should be recognised, as indeed it has been by the government in the area with the changes to the after-hours grants, almost doubling the payment for practices providing full-time care. The bottom line with the evidence-based and consultative approach we took for the remodelling of the ASG-CRA process is that I'm very pleased to state there have been minimal issues moving to the new system and few complaints, although there have been some, have crossed my office. It's a significant improvement on the huge number of anomalies identified with the ASG-CRA system. Doctors in smaller rural towns will now receive almost twice as much under the Rural Retention Program as before. I nevertheless remain committed to keeping a strong watch on the system with a process to review any anomalies that emerge, reviewing the other recommendations from the panel and continuing to engage on appropriate further incentives that will help achieve the goal of the right doctor with the right skills to meet the needs of rural and remote communities. I come to another issue that is current, the changes to the General Practice Training Program. I do know that there are many concerns among rural and regional doctors about the impact of these changes and particularly the perceived increased centralisation. They don't fall within my particular areas of responsibility, but I will be working closely with Minister Lee on the impact of the changes on rural practices. I don't want rural practice to be seen as the default option for doctors who cannot get a position in urban areas. I want to ensure that smaller rural practices get the support they need to continue to provide high quality training, and I don't want trainees to have disincentives for seeking their training in rural and remote areas. Thank you. Ladies and gentlemen, I get it that selection for any rural training program must be more than simply a question, do you want to be a rural doctor? To this end, I know that many of you want to see a restoration of a rural-based program for junior doctor training. The independent expert panel report was strongly supportive of this. It is hard to argue with the results of one practice reportedly having a 70% uptake of doctors now working for or training in regional, rural or remote areas as either GPs or specialists. Many of these trainees may have self-selected into the rural attachment, but the results are impressive nonetheless. This emphasis that selection for rural is not about an interview for a GP registrar post, but a systemic process that begins probably in high school or earlier with growing up in a rural area. Believe me, I get it. I understand that the benefits of rural community-based training go way beyond the immediate workforce support provided by these doctors. I get it that practices and communities benefit from having a vertically integrated teaching environment that helps build immediate capacity and longer-term sustainable practices. I get it that there is a valuable teaching and learning experience to be had in rural practice, whether or not the doctor ultimately wants to become a rural generalist, regional specialist, city GP indeed, or highly qualified super city specialist. And talking to somebody recently down in central Victoria, they were talking about this program, and the person had gone on to be to work as a specialist in a practice in Melbourne. But when they were talking to people out in the regions, they actually understood what was happening out in the rural areas because they'd been there. I get it that having a throughput of recent graduates brings new ideas in clinical information and skills to practices. And I get it that having doctors from local regional hospitals can improve communication between rural towns and regional services that is good for patient services. And I get it that with the increased graduation and doubling of medical school intakes, that we do need to provide expanded opportunities beyond hospitals for junior doctor training. And I was recently with Lucy Walters in the Riverland, and I'm very supportive of the proposed model that she put to me there. I understand that the Rural Registrar program will be far more effective if we have a longitudinal self-selecting process starting with medical school selection and attachments in rural practices through to junior doctor training and registrar training. The problem is that within government, the PGPPP was and still is seen as a very expensive program, and the government has funded 300 more GP registrar training places. So, I need your support to engage positively with your communities, state governments and local members of parliament to help build a greater awareness of the workforce issues and build sustainable models of rural practice based on teaching and learning paradigm with enough capacity to provide continuity of services from primary care into extended settings such as hospitals. And by the way, please just write down on a piece of paper today what you think a rural-based junior doctor training program could be called, and give it to Jenny Johnson or Marita Cowie and they can pass it on to me. Now, entry into general practice does not exclusively occur through the General Practice Training Program, the RVTS, or ACRM's independent pathway. A number of doctors, particularly those from overseas, do not have access to these programs and operate within sometimes limited general registration and with varying degrees of supervision and support. This raises, in my mind, a number of questions that should be answered. Some of these are: do we have enough doctors in the bush? Do we have enough of the right doctors? Numerically, government policies have seen a significant increase in regional centres and rural towns, but are these doctors the right doctors with the right skills to meet community needs? When I note the difficulties with after-hours care in some areas and a decline in hospital-based services, I definitely wonder. Given the increasing numbers of Australian graduates and the maturation of the regionalisation of medical schools, do we still need to have the same emphasis on medical migration to solve our workforce problems? If we have this system, which is heavily funded, highly regulated, with curriculum and standards driven through GPED or RVTS or ACRM, what drives the quality and outcomes in the parallel system? What happens to those doctors and their families who are obliged under a moratorium to practice in the country, often in very isolated regions? There are many more questions, and I am convening a standing rural health roundtable to discuss how we can improve policies in workforce and other important areas. I'm delighted to inform you that the first meeting of this will be on Friday the 13th of November in Canberra. And I'm expecting that Friday the 13th won't be a bad portent. Last year when we met, I said I wanted the right doctor with the right skills to meet the needs of rural communities. If the first 2 years were about fixing the ASG-CRA and Rural Incentives Program, as the Minister for Rural Health, I now want to put a strong emphasis on tying together a raft of initiatives and see how we can make them work better for rural communities. I want to build an educational, professional and economic framework that supports communities and yourselves to develop sustainable practices and provide services that these communities need. So, now I want to say, right doctor, right skills, right model to meet community needs. Ladies and gentlemen, as you know, my friend and colleague, the Health Minister Susan Lee, has initiated a review into the MBS. Our clinician-led review of the Medicare benefit schedule is currently asking health practitioners to identify services that provide no or negligible clinical benefits or that might actually be unsafe or out of date. The review task force is also looking at the current MBS rules and arrangements which are outmoded, ambiguous or do not actually help patients to access the MBS services they need. And can I say, I am very aware of how important it is that we take into account any of the potential impacts and we need to take into account the necessary consideration when it comes to those impacts in our rural and regional areas and our rural and regional practices. The aim of the review is to ensure that taxpayers are funding an MBS that is contemporary, reflects current clinical best practice and covers services that are appropriate and do improve health outcomes. This process is long overdue. Of the 5,700 services currently on the MBS, most have never been reviewed. It makes sense to undertake a comprehensive systematic analysis to ensure our health system is more flexible and efficient into the future. While the core focus of the review is on existing services, there is some scope to consider amended or new items, and new services will be considered by the Medical Services Advisory Committee. This is an exciting time and presents a fantastic opportunity for the community to get involved with shaping the future of the MBS. I was speaking recently with Prime Minister Turnbull and he's made no secret of his desire to see a greater investment in innovation, which is tremendous. In rural, regional and remote health, I'm excited about the opportunities that this process affords in areas like remote monitoring and telehealth, areas where we know the MBS hasn't kept pace with modern rural, regional and remote practice, but I'm also mindful of any potential impact on our existing practices on the ground in our rural communities. I urge you to bring your pragmatism to the discussion around the future of Medicare. Engage with Minister Lee, myself and others in government. Bring your optimism and practicality to the table. In conclusion, ladies and gentlemen, I believe the announcement of a Minister for Rural Health, as I said, is a really positive sign from the Prime Minister and indeed from the whole government. I have a broad portfolio brief that is important for rural communities, and I really do appreciate the help and advice I get from many of you who are here today. I want to continue to keep a watch on the Rural Incentives Program, but work with you to see how we can address the number of areas in workforce policy that we face together. And I need your help in promoting the change in mindset from a doctor, any doctor mentality, so that rural communities can benefit more as we get the right doctors with the right skills and the right models of healthcare for rural, regional and remote Australia. I wish you very well for the rest of the conference. I thank you very much for having me here today, and I look forward to working with you all into the future. Thank you.